author Virgil Sir Frederick Banting, who discovered insulin in 1942, a major breakthrough in diabetes treatment. And as you are aware, we, as part of the National Program for Non-Communicable Disease, are undertaking activities to address various NCDs, which include diabetes mellitus 2. So right now we are focusing on type 2 only, but now we are progressing further to include the type 1 diabetes too. So for this detail, I tell you later. Program further is committed to inform the healthcare providers to update their understanding of epidemiology, burden of disease, underlying risk factors, with special focus on prevention and adoption of healthy lifestyles, and ensuring adherence to the standard treatment protocol. And program is a holistic and comprehensive approach. Uh, and for diabetes care, it includes the physical, societal, and the mental well-being. And this aligns with the World Diabetes Day theme too, which says diabetes and well-being. And this focuses on quality of life for those who are living with diabetes. As you all know, under the Free Drug Service Initiative of NHM, financial support is provided to states and UT for provision of free essential medicines, and quality generic medicines are being also made available at affordable prices to all. And under the Pradhan Mantri Bharati Jan Aushadhi Pariyojana, in collaboration with the state government. So here today we, as a healthcare providers, we have a responsibility for the community engagement. So for this, we need increased participation through our community outreach program, screening camps, educational workshops, and highlighted leaders. They are very important in our program. Now they them to reach all the masses because there are so many culture or societal barriers which they can actually address. Not taking too much, not going to talk too much about this. Um, we are proceeding towards the actual webinar for today. So today's webinar is about the type 1 diabetes, for which we have Dr. and Professor Sujay Ghosh. He is endocrinologist at IPG Kolkata. So, one request to all the participants. Sir is an esteemed expert, so all are expected to write their question and answer in the question and answer tab only. Don't write in the chat box because otherwise the questions may be missed by our consultants. And so, because we are already late, so I just hand over the floor to Dr. Jay Ghosh to kindly take over. Over to you, Dr. Sujoy.
Good afternoon, ma'am. Thank you very much. A warm welcome to everyone present in today's webinar. As Madam has already explained, most of the times we are actually concentrating on type 2 diabetes. Now, we do understand when we were, say, undergraduate students, we were kind of taught that, type 1 diabetes happens mostly in the Scandinavian nations. But because our denominator is so big in terms of India's population, we cannot ignore our population of type 1 diabetes. So even if the proportion of people with type 1 diabetes in India percentage-wise might be not that big as some of the Western worlds, but we in India actually have the highest number of people living with type 1 diabetes below the age of 19. And I've been given about 15 to 20 minutes at the most to talk about in brief about type 1 diabetes, to sensitize all of you to understand about the public health importance and what we as healthcare professionals should be gearing up to do in terms of management of type 1 diabetes, diagnosis, treatment, screening. And at the end, I would take all your questions if you have any. That's the kind of a brief overlay of the presentation that I'm going to make. The first thing that I stated already is that, unlike what rest of the world thought, that India does not have too many type 1 diabetes patients, the previous International Diabetes Federation Atlas stated that India has about 2.29 lakh individuals living with type 1 diabetes. In a recent publication on the type 1D index paper that has been published, it is estimated that almost close to 10 lakh people in India live with type 1 diabetes. And the challenge and the problem is we suspect that this is actually only half of what the numbers should have been. Most of the people don't get diagnosed with type 1 diabetes. Unlike type 2 diabetes, where even if you're undiagnosed, you will live and survive for a pretty long period of time. If a type 1 diabetes individual is not quickly diagnosed, the child or the adult will simply die within a few days of undiagnosed type 1 diabetes. That's challenge number one. So, this entire team of people who are watching this webinar, I think the first thing that all of us need to do is to get sensitized to understand how do we suspect, when do we suspect, and how do we diagnose type 1 diabetes. That is just one bit of the story. The second bit of the story is now India has progressed since independence, and the average life expectancy of an average Indian at this point of time is somewhere close to about 71 years. Now, the average expected life expectancy of a person living with type 1 diabetes in India is only about 34 years. That means the individual loses almost 45 years of life. That is really a staggering fact that we have in terms of the number of people that we lose to type 1 diabetes. And the figure on the left actually kind of shows us that percentage-wise, if you're looking at 1 out of 10 individuals with type 1 diabetes living in the world is actually an Indian. So we've got a big number of people. We have a bigger number of people that we failed to diagnose and who we have actually allowed to pass away. And even the ones where we've diagnosed, our level of management at present is suboptimal, as a result of which we are losing 45 years of valuable life. Now, this is a recent publication that was published about 5 or 6 weeks ago. This is a publication from the ICMR Young Onset Diabetes Registry from one of the centers in New Delhi. And if you see, out of almost about 900 people who had been diagnosed and enrolled in this center, after a median follow-up of about 6 years, a little bit more than that, 11% of our children died. That is quite a staggering fact as well. And there are multiple reasons for these deaths, but we've got to remember that one of the major factors is very poor glycemic control, poor follow-up, and high mortality. And this is one of the best tertiary care hospitals of North India. So you can well imagine what happens in most of the primary healthcare setups and the secondary healthcare setups. Because we in India, even I work primarily in a tertiary care center, India is more about the villages rather than the bigger cities where some of us are fortunate enough to live. Now, just a brief understanding about how type 1 diabetes is very different from type 2 diabetes. Now, in type 2 diabetes, which happens in most of us in adults, the insulin does not work well. So the pancreas is producing insulin, sometimes more than required amounts of insulin, but that insulin does not work well. And as a result of this insulin resistance, combined with a relative insulin deficiency, the function of insulin is hampered, as a result of which the glucose does not enter into the cell, it remains in the circulation and causes the complications of diabetes. So that is type 2 diabetes. So in these individuals, we would normally, apart from lifestyle measures, advocate the use of a few tablets. And in most of the cases, at least for the first 10 years after diagnosis of type 2 diabetes, the individual will not need insulin for the management of type 2 diabetes. On the other hand, if you're looking at type 1 diabetes, this is a situation where the beta cells in the pancreas are absolutely destroyed. Now, that happens because of an autoimmune process, and as a result of which there is absolute insulin deficiency. And we know an individual cannot survive more than 24 to 48 hours without insulin. So the treatment of type 1 diabetes is insulin, insulin, and only insulin. Now, one of the things that we often find is the inability of the family or the subject to actually accept the fact that for the rest of the life, the individual will have to be on insulin. As a result of which, as part of normal human behavior, the patients as well as their parents often seek help from alternative medicines and even quackery. Please, please, please tell all your children and patients with type 1 diabetes, जो आपको जो करना है कीजिए, लेकिन इंसुलिन बंद मत कीजिए. because if you stop insulin, the child is likely to die within 48 hours. So there's a basic difference that you can understand, that in type 2 diabetes, your treatment options include certain oral medications, injectable agents, and insulin for management, whereas in type 1 diabetes, your only medical treatment option is insulin. Now, the second thing that I was trying to tell you was that we need to diagnose type 1 diabetes. What happens is, in a hospital setup or in a healthcare facility setup, we usually have a glucometer at the accident and emergency, and we have it in the wards and in some of the clinics. Now, the challenge is when an adult patient comes in, we are often doing a blood glucose test with the help of a glucometer, even routinely, even when there are no symptoms. Unfortunately, we do not have the same habit of doing the same when a child comes into our clinic. Often the pediatrics ward, the pediatric emergency does not even have a glucometer. So after this webinar, if all of you ensure that whenever anyone is seeing a child, there is availability of the glucometer. And when do you suspect? The commonest 4 symptoms is remembered as the 4 T symptoms. T for thirsty, T for tired, T for toilet, that means passing urine more often, and losing weight, that is getting thinner. So if any child comes to you where there is increased thirst, increased hunger, increased tiredness, increased micturition, and loss of weight, please think of diabetes and do a blood glucose test. A more detailed signs and symptoms, like I said, would number 1 be polyuria, that is passing more urine. Number 2 will be increased thirst or polydipsia. Number 3 is polyphagia, or the child is eating more and there is unexplained weight loss. And there is often excessive fatigue. There's blurred vision, that the child is unable to see. And this last bit that I've talked about is stomachache, nausea, and vomiting. These are features of diabetic ketoacidosis. Please, 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 we don't want our children to be diagnosed with diabetic ketoacidosis. Unfortunately, in India, most of the type 1 diabetes patients that we see have actually been diagnosed at this stage, where they're presented with altered sensorium, nausea, vomiting, pain, abdomen, which actually increases the mortality. Every episode of ketoacidosis means that there is a greater risk of death for the child. So I've sensitized you about the possible symptoms when you suspect diabetes in children, and you should be doing a glucose testing. Now, if we think of the 4 basic cornerstones of management of type 1 diabetes, one, as I said, the most important bit is insulin. The second is checking blood glucose. The third is education, counseling, and self-management. I think we cannot undermine the importance of this. And of course, regular monitoring, follow-up, checking for comorbidity and complications. So I will talk about each of these in detail in subsequent slides. So if you're looking at the components of care, number 1, the most important, like I said, is timely diagnosis and referral to a setup, preferably a district general hospital or a tertiary care setup for treatment or initial management of type 1 diabetes. If you've not done that, you will lose the child and the rest of the boxes remain irrelevant. Once you've diagnosed, we'll talk about case management, glucose control, and all of these bits and pieces. So like I said, when you have a child who has any of these symptoms, or either it could be the emergency symptoms or it could be the non-emergency symptoms, please check the glucose with the help of a glucometer. If the blood glucose is more than 200 milligrams per deciliter, make sure that you ensure that you also, if you have facilities, check the urine ketones. If the blood glucose is less than 200, type 1 diabetes might not be that important at that point of time, but depending on the symptoms, you will have to reassess the child. And remember, if you find a child with diabetes, do not think or worry about whether this is type 1 or type 2. Start the child on insulin. The insulin will save the child's life, and then refer on the patient to a specialist who will then try to think of whether this is type 1 diabetes or type 2 diabetes. Now, if the patient has come in with emergency signs and symptoms of ketoacidosis, ketone is present, we will think of management of diabetic ketoacidosis. That is beyond the purview of today's webinar. That's an emergency situation to be dealt at the level of district general hospital or a tertiary care center. Now, if the Otherwise, you've diagnosed someone with type 1 diabetes, we'll talk about case management. So the second way. So in this, number one, first of all, make sure that the child put on insulin. That is the second box here. And we will talk about how you start that insulin and what regime. The second thing, there is a set of tests that we need to do, which we'll discuss later on. Most importantly, we'll have to educate, counsel, and support the child. What we find often is the child is diagnosed in hospital, the medication and things like that have been given, but the education bit is incomplete. The child goes home, falls ill again, and either lands up in the hospital again or does not survive. So that is also very, very important. So in terms of all of these things that we are talking about, the management of the disease, the first bit is lifelong insulin therapy with multiple injections per day. So in these individuals, we cannot stop insulin therapy. That's step number one. And what kind of insulin do we use? So let's discuss that first. So in an individual like you and me, who by God's grace still don't have diabetes, we know that there are two different patterns of insulin secretion. Even while listening to this webinar, even if you're not physically active or not eating anything, there'll be some amount of insulin that is continuously secreted in the body. And that is what is called the basal insulin, this black line that you can see. So all through the day, some amount of insulin is being secreted in the body. Now, these peaks that you see, immediately after a meal, whatever you have eaten, that starts getting digested and gets into the system, and the sugars should have risen. It does not, because there is some amount of small amount of rapid acting secretion of insulin. So you can see in an individual where you're treating for type 1 diabetes, where there is no insulin, you're basically trying to copy this. So if you are treating an individual with type 1 diabetes, you will have to give one injection of long-acting insulin that will work 24 hours, and the fasting glucose level will tell you whether the dose that you have given is correct or not, and 3 short-acting insulin, each one given prior to each of the meals. And whether that dose is correct, you will know by checking the glucose 20 minutes, 2 hours after that particular injection. So this is something that we have to keep in mind. The second thing that we talked about is self-monitoring of blood glucose. Sorry, I forgot to talk about the injection side. This is again very important because in most of these situations, if the child is too young, we would educate the parent to give the injection. But once the child is above age 5, we encourage the child to take the injection himself or herself. The two commonest sites that we use for injection, as you can see in the highlighted area, is the area in the abdomen and in the thigh. We usually encourage to give the long-acting insulin injection on the outer side of the thigh and the short-acting insulin around in the abdomen, leaving around 2 inches from the navel area. Because the abdomen, the absorption is quicker, and the outer thigh, the absorption is slower. So in terms of the glucometer, the first thing that I would like you to look at is this picture. Where has the finger been pricked? It is not the tip of the finger that you prick. This holds good for children as well as adults. The tip of our fingers are the most sensitive areas. And imagine pricking yourself every day in the tip of your finger. It hurts. So always try to rotate the site and always try to prick the sides of the finger. It will actually hurt you less. Now, this battle against type 1 diabetes, if you look at insulin as your sword, the shield is your glucometer. So without glucose monitoring in type 1 diabetes, just taking insulin is absolutely of no use. So we usually encourage the patient to actually check for the blood glucose on an average 3 to 4 times daily in a child with type 1 diabetes. Now, when do you test? How do you test? This is one way that I've shown that you do it in a staggered manner. So in 2 to 3 days, you have an idea of what is happening all through the day. Again, remember, ideally the patient should probably have an idea of the pre-meals as well. That will help in adjusting the dose of the insulin that the child takes before each dose. And whenever the child is not feeling well, it could be a hypoglycemia or a hyperglycemia. The third thing that is important about monitoring is you've given insulin, you've given glucometer, but you've not taught the parent and the child how to adjust the insulin regime and the lifestyle according to the readings, then this monitoring is of no use. A little bit about nutritional management. There's only so little that I can talk in about 15-20 minutes. The most important thing is keeping a check on carbohydrates. And it is important that initially we do not jump into complicated things like carb counting or carbohydrate counting for the child, but at least knowing that you will have to give minimum amount of certain carbohydrate, and choosing what kind of carbohydrate you give the child is very important. We mostly encourage complex carbohydrate intake and avoidance of refined carbohydrates. So accordingly, our traditional Indian diet is very good in complex carbohydrate. Whether we are taking chapati or whether we are taking rice, we can modify that addition of the millets, for example, and complex carbohydrates we can take. Now, if you want the glucose to rise relatively quickly, for example, somebody is exercising, simple carbs, but try and avoid refined carbs. Fats provide important source of energy, but avoid too much of calories by giving too much of cooking oil. And try, which is very advanced, which we don't teach our patients unless and until we've been able to manage to sort out the basics of diet in our children with type 1. This is like to class 2. Let us finish class 1's education. Then this is probably something that we will teach at an activity is very important. Some of you would be watching competitive sports. For example, this year's Wimbledon finals, those who have won. This year's runners-up is an individual with type 1 diabetes. So we recommend physical activity and exercise, and making sure that you don't do unaccustomed exercise. There will be, your doctor will be, and your healthcare professional, particularly your educator, NCD counselor, will be able to tell you about how to cater to your exercise pattern and how to monitor glucose levels both before and after exercise. Remember, it is common knowledge to think that I exercise, immediately after that the glucose will just come down. Every individual has a different pattern. For some, particularly those who have uncontrolled diabetes and high sympathetic activity, the glucose will rise after an exercise. Depending on what degree of exercise you've done, the glucose might go down immediately after the exercise. Or you can have hypoglycemia and the glucose might go down even 4 to 6 hours after exercise when the muscle is again trying to rebuild on the glycogen storage. One of the most important things that we need to teach our children with type 1 diabetes is what to do on the days that they are unwell. If you are living in India, you will definitely fall ill on certain days. You will have fever. You do what on the sick days. So I've tried to put down a very simple mnemonic. If you first remember S, on days that you're unwell, you have to check your blood glucose repeatedly because they can be very, very high. Even if you're not eating, the levels can be very, very high. And depending on the levels, you might have to seek emergency medical services. The second is I. I is for insulin. Unlike the other days, you might need more amounts of insulin, supplemental amounts of insulin. That is something that we need to teach. The C is for carbohydrate. So on these days, we have to ensure that however unwell the child is, some amount of carbohydrate the child will have to consume, otherwise the child will go into ketosis, and ensure that the child is adequately hydrated. Because once the glucose goes up, the child starts passing more and more urine. So any kind of fluid, whether it is dal, whether it is plain water, whether it is coal or something like that, we have to go on hydrating the child. And you should have facilities for checking the ketone bodies, that's the ketone. And when to refer. If you're unsure, it is best that you go to your doctor. However trivial and however silly you might feel, that it is better to be safe than sorry, number one. Number two, if the child is unable to take anything by mouth, then you should take the child to the hospital for admission. The second thing, you are giving a lot of supplemental insulin and still the glucose is high. If the child is febrile, if the child is feeling drowsy, or the child is lethargic, you cannot wait for even 1 or 2 hours. Go and seek help immediately. Now, when the child is normally well, when we are looking at a day-to-day follow-up of the child in your clinic, we ensure that we actually measure the body weight, the height, the BMI, the blood pressure. It's very important to check the insulin sites whether there is goiter and acanthosis. Again, one of the things that we often forget is to look at the supplies that were provided to the child. Have they been used? And what is the glucose readings? And from time to time, these are the readings that we will be doing. There's a checklist that your doctor will know which to do how often. I'll share that list as well. This is the standard list of what tests to do at what frequencies. Remember, the comorbid conditions that can happen is thyroid disease is very common in type 1, particularly northern India and western India has high prevalence of celiac disease, high blood pressure and cholesterol. These are the comorbidities, and we need to screen for complications of diabetes on a regular basis. And also, because this is a child, you have to monitor the growth as well as psychological well-being of the child as well as the family. I've already talked about emergency care. That is most important if you have a hyperglycemic crisis or a diabetic ketoacidosis. But also remember, hypoglycemia, if it is severe, will need emergency care. Now, in terms of the framework of managing individuals with type 1 diabetes, if your healthcare facility is actually trying to look after children with type 1 diabetes, you have to make sure that you have a system of enrollment at initial visit. You do the routine anthropometric tests, manage the disease and complications as I've told you. Required laboratory investigations have to be done. And you have to dispense insulin, consumables, glucometers, and other things. Patient and counseling is very important. Make sure you see the child every month. Daycare facility and emergency care services have to be available. You have to have a tie-up with the nearest tertiary care system, and data keeping and stock maintenance is important. So when do you send to a tertiary care center? Number one, I already told you, if there are acute emergencies, there is very poor metabolic control, there's complications, or if an individual is contemplating to get pregnant or is pregnant. Now, coming to the last bit of the presentation, Madam was talking about how important role of community and support of health groups and support groups, particularly formed by people living with type 1 diabetes, is important. They play an unbelievable role. We working in the healthcare system, we are not always able to provide the kind of education, help, and support, particularly certain states, for example, Tamil Nadu, Kerala, Delhi. There are many such support groups, even Ahmedabad, where they are doing fantastic work. And even some of you might know in Aurangabad, there's one of the centers where the mothers are providing help and care and support in terms of voluntary work. These support groups will be able to provide the level of education and psychological support, which often we as healthcare professionals cannot do. And therefore, one of the things that we as healthcare professionals need to do is we have to ensure that we create such networks, we support such networks. They are doing an extraordinary job, and we just cannot manage type 1 diabetes without their help. So the challenge of type 1 diabetes is it's not that we don't know what is needed to be done. The challenge is we are not implementing what we already know works. So here comes the question of implementation of currently available knowledge. So I think I'll try and stop there because I think I've spoken for a long time, and it's best that I take your questions at this point of time. Thank you very much.
Thank you, sir. That was a great session. Now we will take some questions. So we have 2 questions in the question and answer box. The first one is by Dr. Ahmed. Weekly, twice, or any time I'm facing common problem, that is patient used to take diabetic medicine from private hospitals since 2-3 years or 6 months or 5 years. That will be advanced medicine. And now coming to government PHC, they want to take the government medicine from our PHC, as in basically metformin E or Glimi is available there. So what to do for those patients who is taking already 3 to 4 combination of medicines from private, and that is different from the formula that we have?
I think this question is relevant for adults with predominantly type 2 diabetes and not type 1 diabetes, because like I said, in type 1 diabetes, your only treatment option is insulin, and insulin. Now, in terms of type 2 diabetes, we know that this is a disease where there is a relative insulin deficiency, and over a period of time, the individual will fail to produce enough amount of insulin. So we go on adding tablets one after the other. Then you increase the dose of the second one, then you have third one and the fourth one. Now, I kind of tell my patients that I really do not care what tablets or insulins you take in type 2 diabetes. Two things matter. Number one, are those tablets at that point of time safe for you to use? Because, for example, you've got a kidney disease. Some of the tablets you cannot take. You've got liver disease. You cannot take some of the tablets. Somebody's contemplating to get pregnant. You can't take those tablets. Whatever combination you take, if you're able to achieve good glycemic control safely, I'm happy with that. So it does not really matter whether you're taking tablets from the PHC or from a tertiary care center. Remember, we have so-called progressed in diabetes over the last 100 years, but we know ultimately all of our patients in type 2 diabetes, if they're alive for more than 10 to 15 years after diagnosis, most of them will need insulin. So if they are taking a certain class of tablets which they were being given in tertiary care center, which you cannot provide in the primary health care center, be honest about it, tell the patient कि हमारे पास सिर्फ यही है, अगर इससे काम नहीं चल रहा है, and if you cannot afford it, then please we can offer you the option of going on to insulin.
Okay, sir. The next question is from Vishal Gupta. If the patient is on fixed dose regular insulin and goes into hypoglycemia, so in this condition, do we have to administer fixed dose
Right.
insulin or not?
So I think that's a very, very good question. So the first thing that we educate our patients is कि आप थोड़ा सोचिए वो हाइपोग्लाइसीमिया क्यों हुआ? Why did you have that hypoglycemia? आप क्या खाना नहीं लिए थे, कम खाए थे, or were you physically more active on that day? So that could be for that particular day to figure out. So we know that there are three things which control blood glucose or is dependent on. आप क्या लिए थे खाने में? That's your income. और आप क्या खर्च किए थे उस दिन? What physical activity did you do? That's your expenditure. And the third is the dose of the insulin. Now, if you had skipped a meal on that day, or if you took a late meal on that day, or if you had unaccustomed exercise on that day, we straight away know that we can explain this episode of hypoglycemia. For that day, we manage hypoglycemia by giving some amount of oral carbohydrate, depending on the severity of hypoglycemia. But we know that it is a one-off phenomenon. We don't need to probably change the dose the next day. However, if you're having the same kind of hypoglycemia at the same time with the same amount of lifestyle in terms of the dietary intake and the exercise, we know there is a mistake or a problem in the dose of the insulin that you are giving. There we need to readjust the dose of the insulin from subsequent days. That's number two. Number three, if you have been relatively stable, diet is same, you were requiring X amount of insulin at that particular time of the day, now you suddenly find that your dose requirement has to be reduced over a period of time. The other thing that you start thinking is, am I developing an organ dysfunction? मान लीजिए किडनी खराब हो रहा है, liver खराब हो रहा है. So those are situations where you will have to screen for complications of diabetes or why that hypoglycemia is happening. So it's important that when a hypoglycemia happens, of course, you manage it immediately for the immediate time being, try to prevent what is happening thereafter on that particular day. But दिमाग लगाइए कि ये क्यों हुआ? And sometimes you will not be able to find a cause, but on every occasion you should try to figure out why this happened. So if you are able to answer that why, you will then know how to sort out that problem.
Next question is from Dr. Rashid. Does the long-standing use of insulin hamper the beta cell to decrease secretion of insulin as a part of body's hemostasis?
No, actually. See, basically, God is very intelligent and has made our body in such a manner that even when you are diseased, just by giving insulin is not going to, help the insulin system recover. And like I said, normally in diabetes type 2, there'll be a gradual decline in the insulin production. So you will need insulin in the long run. In type 1 diabetes, unfortunately, from the very beginning, you don't have any insulin. So with this, so giving insulin from outside no longer does anything to the beta cells of the pancreas. जो चला गया वो चला
Uh, Next, we have Kaushal Gupta has asked, sir, do stem cell implantation has any role?
Well, let me answer that question from a public health point of view, from a scientist point of view, and at an end user point of view. See, some of you would have read Nature paper that got published about 2 months ago. So stem cell research is still in the stage of research, and there also the stem cell research shows that you are off insulin for only a very short period of time. The longest duration studies that we have right now is about 400 days. Now you can't go on repeating such a procedure. It's a very exciting area. Hopefully, in near future, at someday, some point, scientists will be able to give us a permanent solution. But as of now, the answer to stem cell research from a public health point of view and from an individual point of view is not something which is sustainable.
So next one question we have from Dr. Mahesh Kothari. A patient having polyuria, but sugar levels are normal, and age of the patient is 47 years. He's male, and urine sugar is also negative. What to do next? Ultrasound also shows minimal amount of post-voidal urine, no prostomegaly.
Right. So you have given a classic situation what happens in type 2 diabetes or otherwise, even without diabetes, in individuals above the age of about 45 years. So we call them lower urinary tract symptoms. This usually is often associated with prostatomy. So just imagine there is some reason why the urinary outflow tract pathway, there is a problem. So when you're trying to pass urine, there is inadequate voiding of urine. So some amount of urine stays in the bladder, and after a while, you again have this urgency, hesitation, and the desire to pass urine. So in such a situation, we usually ask for a urodynamic study to figure out is there a dynamic obstruction at the level of the urinary bladder, and consult a urologist in such a circumstance to figure out whether there is a problem like that. In terms of polyuria, please remember we often tend to use this term, quite colloquially. Polyuria means number one, frequency is increased and the volume is increased. In the patient that you've described, I think the frequency has gone up, not necessarily the volume of urine in 24 hours has gone up.
You sir, one question we have, should we start a diagnosed PCOS patient with impaired glucose tolerance but normal HbA1c who's planning for pregnancy with the treatment?
Right. So, basically, when we talk about metabolic syndrome, there's a whole lot of disorders that follow. In that is diabetes, hypertension, dyslipidemia, and polycystic ovarian disease. And the basic underlying problem is insulin resistance. Now, that insulin resistance manifests in different individuals in a different manner. Some might present first with diabetes, some might present with polycystic ovarian disease. Now, a lot of women that we see who have polycystic ovarian disease might have infertility, might have irregular cycles, and their glucose levels might be already impaired with a normal A1C. Now, remember, when we talk about diagnosis of diabetes, we usually tend to use one of four criteria repeated on 2 occasions. Either fasting is more than 126, or post-meal is 2 hours is more than 200, or HbA1c is more than 6.5, or a random glucose is more than 200 with symptoms. Now, ideally, you would want concordance in the diagnostic criteria between these 4 criteria. But often you will find that the patient is fulfilling only one of these criteria, not necessarily the other, particularly in the early stages of dysglycemia. So in the particular individual that you're talking about, if the individual is obese, I will encourage the person to lose weight and try to achieve near normal glycemia in the OGTT before I allow the patient to go ahead and conceive. The challenge is pre-pregnancy counseling is still in infancy in our nation at a public health point of view. This is something that we should actually hammer on, that you should get the clearance from a healthcare professional before you conceive. And in that, one of the things is ensuring that the weight of the mother is normal and the glycemic excursions of the mother is normal.
Thank you, sir. So many participants have said thank you, and they showed that it was a very great session, sir. In the interest of time, sir, we won't be taking any further question, and I would like to answer all the participants. That presentation that sir has given will be shared through the same email IDs with which we have sent the invites for the webinar, and they can access the presentations through their states and districts. Thank you so much, sir. I would
Thank you.
request Dr. Ravesh Agarwal, sir, now to please give vote of thanks, sir.
Yeah. Am I audible, Shweta?
Yes, sir, you are audible, sir.
Okay. So I must thank Professor Dr. Sujay Ghosh. Sir, listening to you personally and for the audience, it is like a dream coming true for all of us. And you have explained us all about type 1 diabetes, which is, of course, a subject of which even the doctors and the healthcare workers, apart from the general public, they are generally not aware. And beautifully, you explained that it is the identification, early identification of the symptoms, and not letting the patient, the child or the adult, getting into the severe form of ketoacidosis. And then, because the mortality rate is certainly very high, sir. So, sir, as we are fortunate that sir has already answered many of those questions and had spent so much time with us. So, I must thank you again, sir, on behalf of the ministry and the DGHS office for coming on this webinar and enlightening us. So, thank you very much, sir.
Thank you.
So, Abdeji, we can
Yes,
close the
sir. Thank you
session.
so much,
Yeah.
sir.
Thank you, sir. Well noted, sir. Thank you, everyone.